All right. Hello out there, everyone. Dr. Brown coming to you with another edition of Raising Your Revenue. So, today we're going to chat a little bit about thyroid labs, what this patient might look like when they walk in your door, what labs you might order to figure out what's going on with them. Okay, so with thyroid labs, you guys, you probably are used to the typical uh, thyroid patient that comes in. They can complain about things like brittle hair. Um, they could be overweight, right? If it's hypothyroid, they could be overweight. Hyperthyroid, they might be underweight because the thyroid is basically the mechanism by which we control our metabolism. Um, they might come in complaining of heat intolerance, right? In other words, their body is really cold because it's hypothyroid, and they just can't handle high levels of heat or cold intolerance. Right? Sometimes you also see people come in with the typical goiter you might find in their neck. You can see that coming a mile away. And also, they might have exophthalmos, is a fancy word for those when they have the eyeballs that are pushing outside of their head. All right. So those are some of the obvious signs and symptoms. They might be a little bit jittery. And then when you push it to an emergent end of the spectrum, you can have people with hyperthyrotoxicosis. They have these thyroid storms where their heart starts beating really, really fast. They think they're having a panic attack and don't know what's going on. Okay, so um, which kind of patients might be best fitted for these labs? Well, of course, hyper and hypothyroid patients. Of course, patients who might be grossly underweight or grossly overweight, right? Those are no brainers. Hey, Mr. Jones, let me run a thyroid lab on you. Um, Patients who are pregnant, all right, and I'll tell you why. Because it turns out that thyroid hormone looks a lot like human chorionic gonadotropin, the hormone of pregnancy. It is why that if you wrote down the signs and symptoms of a pregnant woman versus a hyperthyroid woman on paper, it would be difficult to tell them apart. Okay, they would have some of the same complaints. Sometimes my heart flutters. It starts to beat really fast. Oh my God, why is it so hot in here? What's happening with my hair? Right? So, and it's just because that these two hormones um, share a common subunit, and it makes them look like each other. What did I just say? When you have a woman who is pregnant, you should also run a thyroid test on her. Okay, so let's talk about which thyroid labs to run. So here's a shot of typical disease processes and what the labs are going to look like. Which labs? Well, today we're going to talk about three main labs that you'll be concerned about. That's going to be thyroid stimulating hormone, T3, and T4. Okay? Thyroid stimulating hormone, T3, and T4. Now, some of the ones that I did not mention, Graves' disease. That's with the exophthalmos most commonly is how we talk about it. Primary hypothyroidism. So as we're talking about this stuff, we're going to go through some quick definitions of primary hypothyroidism, secondary hypothyroidism, tertiary hypothyroidism. Sounds complicated. It's not. It's just a bunch of fancy words. And we'll talk about how things like pregnancy um, affect your thyroid, and then the same thing on the male side, right? If being pregnant, that is to say, having an excess of estrogen in your body as a woman affects your thyroid hormones, then being a man and either losing your free testosterone or being a man and taking anabolic steroids, taking testosterone because you're a weightlifter, etc. Both of those are the female equivalent of having hormone imbalances that might manifest themselves as thyroid um, perturbations. So let's talk about the labs. So to measure the thyroid function, really, guys, if you wanted to get one lab that is the biggest bang for the buck, then it's going to be TSH, thyroid stimulating hormone. Now, before I explain why, what I need to do is to give you just a quick rundown of what this looks like in the body. And then I think it'll make a lot more sense. So I'm going to switch screens here. Okay, we got basically three body parts, right? And so this is your hypothalamus. This is your pituitary gland. This is your thyroid gland. So your hypothalamus turns out that it's going to put out some stuff that talks to your pituitary gland. Okay? And that's called thyroid stimulating hormone. I'll just put out, I'm not, thyrotropin releasing hormone, TRH. When your pituitary gland hears of it, it puts out what we just talked about, TSH. Okay? Thyroid stimulating hormone. And that thyroid stimulating hormone goes down and talks to your thyroid and says, hey, put out some T3 and T4. Now, some of your patients, when they walk in, they're going to have a problem with their actual thyroid gland. Actual thyroid gland. What does that mean? Your hypothalamus and your pituitary can keep talking to that thyroid gland, but it's broken and it's not putting out T3, T4. So what does the rest of the body do? It starts shouting. Didn't you hear me? Put out more T3, T4. So your TSH goes up when you have a problem with your thyroid gland. What did we just say? If you see a low T3 and a low T4, look for a high TSH. That will tell you that your patient has a problem with the actual thyroid gland. And then the other one's the other one. What if your thyroid gland's putting out too much T3 and T4 because there's a tumor or something? Then what's going to happen? The body's going to say, whoa, wait a minute, slow your roll. We've got a lot of T3, T4 going on out there. Why don't we not put out so much TSH? So your body starts whispering with the TSH. What did we just say? If you pull a lab and you see decreased T3, T4, then hopefully your TSH is going to be, if they're decreased, your TSH is going to be up. And if your T3 and T4 increase, your TSH is going to be down. Okay? Now, without memorizing all of that, what I'm suggesting is you just start with a TSH. If you want to know which way to go on your labs, follow the science by starting with a TSH. If I get a decreased TSH, I'm already telling myself, you know what? If my TSH is low, my body must be trying to whisper to my thyroid gland and tell it, don't put out any more. And the other one's the other one. If I see a high TSH as my first lab, then I should say to myself, you know what I'm going to expect? My body's shouting TSH at my thyroid gland because it's not doing its job. I must have a problem with a low thyroid. Okay, so that's how to think about it. And then last thing, I told you those fancy words, primary, secondary, and tertiary. If I've got a broken thyroid gland, that's primary. Primary whatever. Hypothyroidism. What if I back up one step and I've got a broken pituitary gland? That's secondary. right? If my pituitary gland won't put out the TSH, which my thyroid gland's waiting on, then that's a secondary problem. What if I have a broken hypothalamus? That's tertiary. Maybe it's not putting out TRH. So my pituitary gland doesn't put out TSH. So my thyroid doesn't put out T3, T4. Okay, easy peasy. Big long words, really easy concepts. All right, so now that said, let me go back to the slide set that we were on. Okay, so to measure the thyroid function, you only really need one lab to get you started. You're looking for a normal TSH. A normal TSH is going to imply that there's a normal thyroid. There are some assumptions, right? That your patient is not taking a thyroid drug, for one. Okay. There's also the assumption that the TSH receptors in their body are working fine, and that there's no other abnormalities going on, sodium, iodine, symporter. Um, and it doesn't consider, and we'll talk about this, tyrosine and iodine levels. So what we just talked about, guys, was the feedback principle. When T3 and T4 are high, your body is saying, whoa, let me just whisper some TSH to you because we don't need that much. That means your TSH is low. Other one is the other one. T3 and T4 low, your TSH should be high. So now let's say that you look at that first, your patient's walked in, they've given you an idea because of their complaints and signs and symptoms. You kind of want to give them a thyroid panel, you get it back, and then what you notice is you have decreased levels of TSH. Now you've got to go down your differential diagnoses, right, to figure out which other labs to order if possible. So as we already said, low TSH means hyper, too much, thyroidism. That could be primary here, secondary here, tertiary here, or it could be what they call subclinical primary hyperthyroidism, which means that their labs are messed up, but their bodies aren't showing it yet. But I think you take home my message, which is just, hey, if I look at TSH and it's low, I'm going to start thinking hyperthyroidism. And then what if you look at your labs and you have an increased TSH? Hypothyroidism. Okay. Or if I've got increased TSH, maybe I've got a tumor that's making the TSH and it's just ignoring the rest of my body, no matter what my body says, speed up, slow down, or whatever. The tumor just keeps pumping stuff out. Okay. We talked about the thyroid storm, thyroid toxicosis. Hashimoto's thyroiditis, right? Just another form of a thyroid disease. Lithium treatment, right? One of the problems with lithium is that it messes with your thyroid gland so that you end up putting out too much TSH. Who's going to be on lithium? That's your patient that comes in and might have bipolar disorder, right? Lithium is a first-line treatment for this. So potassium iodide treatment, a lot of people use that who might work around radioactive things, right? Because this helps their body not to absorb, which actually opens up another patient population for you. And then people who are taking thyroid hormone injections. Sometimes people do this as a diet, right? They want to rev up their body's metabolism, so they take these injections where their body's always running at 100 miles an hour, but then they come into you presenting with hyperthyroidism and want you to help them. So there you go. And there's this concept of thyroid hormone that's bound versus what's free. Okay, so there's thyroid binding globulin. This is just a protein that binds thyroid hormone. Some of it's bound. Some of it's just floating around in the plasma free. Really, the only thing that your patients can use is the stuff that's free. That's the only stuff that's metabolically active, is the free thyroid hormone. By the way, that's true of everything, right? When you see these commercials about testosterone, notice that they do a very good job at saying, I think your free testosterone has decreased, because it makes a difference. Okay, so this is the same thing that's repeated there about the negative feedback relationship between T3, T4, and the TSH. And then so the final thing is that what if we have a change in our thyroid binding globulin? Okay, what that leads to is a change in your total amount of T4, bound T4 plus free T4 equals total T4. Okay, so a change in the thyroid binding globulin means that you're going to change your total T4, but it doesn't change the free T4 or the TSH. I know that's a whole bunch of words right now. Let me tell you what I mean. Estrogen increases your total binding globulin. Why might your patient be on estrogen? Maybe she's pregnant, or maybe she's taking oral birth control, or maybe she's got hyperestrogenism. Hyperestrogenism or birth control are going to present with an increased total T4. But you're going to be looking at that TSH and say, why in the world is my total T4 up, but my body hasn't responded? It's one of those weird things. Answer, she's getting estrogen from some other source. She's getting extra estrogen. That's the best way to say it. For the men, the equivalent is the anabolic steroids. It's because, they're going to take weight, they're going to be lifting weights, and they're trying to get muscles in their fingers, so they take the steroids. And the steroids are like, we're going to make muscle, but the body, in helping that guy make muscles, steals proteins from the thyroid binding globulin. So what does that do? It decreases a T4, but strangely enough, no change in your free T4 TSH. What did I just say? When your patient comes in and you found a reason to give them a thyroid panel test, and you look at their total T4, but nothing else has changed, then you ask them, hey, dude, are you taking steroids? Now, there are other things that will cause your patient to have a change in their thyroid binding globulin and also their thyroid hormone. Beta blockers. Who's on beta blockers? This is anybody who tends to get anxious, and they'll take a beta blocker just to slow themselves down and feel better. That could be musicians, public speakers, just somebody who's kind of over anxious. You'll know the personality when they walk in the door, right? Someone with liver disease. Now, we just opened up right now wide categories of patients who it is possible to order these thyroid labs for. Liver disease, that means people who might have hepatitis. That might be young people who might be at risk for hepatitis C. If you have patients who share needles, or they live in at-risk zip codes, or they live at-risk lives, or if you have people with non-fatty alcoholic liver disease or fatty alcoholic liver disease, right? Liver disease, that's an easy place to go. So we just connected liver disease to thyroid test. Proteinuria, that is just putting protein in your urine. So in other words, any disease where you are losing protein is a disease that that you should be checking the thyroid panels on. What's the biggest one? Diabetes, right? One of the end organ problems with diabetes is that it damages your kidney. There's many others. You could have a patient with systemic lupus erythematosus. I mean, there's lots of kidney-related diseases out there to tie this to, and malnutrition. And I don't mean malnutrition like there's a little kid in a third country who's starving with a large stomach. I mean, in America, where you have someone who lives in a zip code that happens to be what they call a food island, right? Where there's no store within 7 miles. And so they're, instead of eating healthy foods, it's just always Cheetos and snacks and Coca-Colas. Okay, so if you've got any patients in that situation, that's yet another justified reason to order this lab panel. And we don't care about that. That's just talking about the proportion that's tied up versus the proportion that's going around free. Iodine uptake. Okay, so if you have more iodine uptake, it means you produce more thyroid hormone, and we've already talked about who takes that. You'll also, if you live in a state where there's nuclear reactors, this is a niche for you. Okay, Plymouth, Massachusetts, there's a little reactor, and everybody in the town keeps a little packet of potassium iodide in their kitchen, just in case of a nuclear accident. Okay, so if you live anywhere near this, this is for you. So here, let's take a look at these labs. You've got a patient that came in. You've got a T4. I see it's low. Well, actually, I'm going to start the way I'm teaching it. I want to go for the TSH first because it's going to give me the most bang for the buck. I measured the TSH. It is high. That means my body is screaming at the thyroid gland. Why? Because now I expect for my T3, T4 to be low. I look up there. There you go. Low T4 and low T3. Okay? So what does that mean? That means that my thyroid gland is the one that's dropping the ball, right? It's screaming out the TSH. So that's called primary hypothyroidism because it's my thyroid gland dropping that ball. Okay, so we have another one here. I'm sorry, that one's kind of small. I start out with TSH, and I've got high TSH. So again, my body's screaming. This is just a different patient, different labs. But really, the diagnosis is the same, right? If I've got a high TSH because my body's screaming, I can anticipate I'm going to have a low T3, low T4. And so we're talking, again, primary hypothyroidism. Okay? So there you go. And what you should be able to do is to find a list of population of your patients who are either presenting with hyper or hypothyroid signs and symptoms. Log into your VirtualClinic portal, and you can order your T3, your T4, your ultra-sensitive TH. If you have a lot of diabetics, right, what do? Well, you can tie on this thyroid panel with your diabetic panel. And so now all of a sudden you've got the Sheila panel, right? If you happen to have an office with lots of diabetics, then yes, check their glucose and their fasting glucose. Also, yes, check their kidneys because, as we said, there's end organ damage. And also, yes, throw on the 3 thyroid panels. Boom, you just made a Sheila panel that is designed for your particular patient population. Okay? So that is how you do that. All right, so I'm going to answer some questions here. When will we be able to access these slides? Actually, you'll be able to access the program because we're recording them now, and you will be able to just play them whenever you want. So yes, you'll have access to the slides and my shrieking voice behind the slides. Okay. And so, hey, good to see you out there, Dr. Dave. All right, guys. So thank you so much. I appreciate your time and attention. And by the way, if you I'm going to do one with Dr. Frank today, I believe. Dr. Dave or Sheila, anybody else. If you're interested in a consult, what we're providing is, the ability for you to give us a call and, give you like a 30-minute free consult on any patients, any problem patients that you might have out there, and then give you some guidance on how to make up your labs, which ones, etc. So just ask for me. I'll probably be heading that up, the consult part of it. You need some advice, a little time. We'll probably do it by cell phone. You can grab your cell phone at lunch. I'll do the same thing, and we'll chat about it. So reach out to support at I forgot, support at Virtual Clinic. Actually, you know what? Let me give you my email. Let's go with t.brown at virtualclinic.md. t.brown at virtualclinic.md. And if that doesn't work, let me give you an alternative. tbrown at post.harvard.edu. tbrown at post.harvard.edu. Okay, guys. Thanks so much, and we'll see you next week. Bye-bye.